Hello everyone, and welcome back to CBCLIPS. After a pause, we're back to the third season of CBCLIPS, and I'm very excited about this season because we really hope to have many guest presenters from around the world and possibly even CBCLIPS in other languages in addition to English. I also want to wish the surgeons who are starting to attend the Egyptian Pediatric Surgical Association meeting and the Canadian Association of Pediatric Surgery meeting today, September 15th, a great meeting in Egypt and in Victoria, British Columbia. This month's CBCLIPS is an episode of a newborn baby boy with a prenatally diagnosed right lung mass who then is born with minimal symptoms, but over the first couple of weeks starts becoming symptomatic and presents with X-ray films that I shared with you that we will review in a minute. This was actually a very unusual and somewhat atypical case. This baby was diagnosed with a prenatal lung mass just at the end of the second trimester of gestation. So it was a very large echogenic mass, as you see here on ultrasound and MRI, started with a significant CPAM volume ratio of 2.4, increased to 3.2, and then decreased all the way to 0.6. The mother did receive steroids as treatment for this mass. As I mentioned, in the scenario, the baby was born without really any significant symptoms, but over the course of the first 2 weeks developed significant increased respiratory rate, respiratory effort, and difficulty feeding. And when you look at the chest X-ray here over the trajectory of the first couple of weeks, you see that we're seeing some collapse of the right upper lobe and more mediastinal shifting and overinflation of the right side. So the clinical principle here is that any baby who has a symptomatic congenital lung mass needs to have this addressed. We all know that there is a controversy as to whether asymptomatic patients should be operated, but I don't believe there's any controversy that symptomatic patients should in fact undergo resection of the lesion causing the symptoms. As many of you suggested, we obtained a CT scan to understand what exactly was happening prior to surgery, and you see here on the CT scan cuts that we have significant overinflation or hyperinflation or emphysema, if you want to call it that, in portions of the right lung. But on the axial view, you'll see that there is some over distension of the lung anteriorly, which corresponds to the middle lobe, but there's also some distension posterior to the heart, and that really should not be the middle lobe. And we know that congenital lobar overinflation or lobar emphysema is very rare in the lower lobe. So this made the case even more atypical. The next clinical principle I would like to mention in this case is that when you're getting ready to operate on a baby with potential congenital lobar inflation, you have to be very careful in terms of the anesthetic induction and the preparation. These babies can actually go into significant sudden collapse if you give them positive pressure. And in fact, early in my career, I had a case that you see here where the lung increased to a massive dimension, the right middle lobe, and the baby had to undergo an emergent thoracotomy to herniate the lobe and resect it. So in this baby, we started right away with left mainstem intubation after putting our necessary lines and so on. We never ventilated the baby in the trachea, and we had the right lung isolated from the very beginning. When we did our thoracotomy, we found that the right middle lobe, in fact, was the culprit. It was very large. It was never ventilated, so did not look quite as impressive as ventilated lobes. But you can see here the size of the right middle lobe, and it was really pretty much larger than the upper and lower lobes combined. The lower lobe seemed also a slightly bit increased in size, but it really did not look overtly abnormal, and we left it in place. The pathology continued to surprise us somewhat in this baby. And by the way, this is a case that was presented in real time. In other words, I presented it when the scenario was still unfolding, and I really didn't know what the final outcome will be. And here you see that the pathology does show the typical findings of congenital lobar overinflation with these large spaces compared to what is normal. But the pathologist also showed some other findings typical of CPAM. For example, there was a decrease in the there was an increase in the bronchiolar structures uncoupled with vessels, things we actually see in the more cystic malformation. So it was not really a typical CLE as we would normally see. The baby did reasonably well. In fact, we removed the chest tube on the third postoperative day, and we were very happy with how the chest x-ray looked, but then went on to develop an air leak that we had to treat, and that was treated successfully. But we still saw some evidence over the ensuing days, some evidence of overinflation. And you can see here that there's still some mediastinal shift with some overinflation in the lower lobe. Now, the baby continued to be completely asymptomatic, feeding well, no respiratory distress, gaining weight, and we decided at this point that we will observe and see what the rest of the baby's trajectory looks like, and the baby has actually been sent home. Thank you, and until another episode of CB Clips.